evening, everyone. My name is Jennifer Wargo, and it's my great honor to be here today with you. And if we could bring the slides back up. Thank you. On linking immunotherapy to better outcomes in resectable melanoma, guidance on integrating immune-based adjuvant and neoadjuvant options. So welcome to everyone in the room, and welcome to everyone who's dialing in from outside. And so tonight's panelists include myself. I'm from MD Anderson Cancer Center. We also have Jean-Vive Boland from the Massachusetts General Hospital, as well as Hussein Tawbi, who's also from MD Anderson Cancer Center. And I'd like to thank Medical Learning Institute and PeerView for providing this session, and for Bristol Myers Squibb and Merck for providing the educational grants for the symposium. And if you haven't already, please complete the pre-event survey, and reminder, just look out for additional follow-up polling during the presentation. And we've already, please submit your questions. We've already got outstanding questions, so kudos to you. And we'll answer them during the Q&A session, but really engaged audience already, so thank you. And so this is the accreditation, credit designation, and supporter statements, and so you can refer back to these should you need any more information on this. I will highlight that Medical Learning Institute designates this live activity for a maximum of 1 AMA PRA Category 1 credit. And in addition to this, we have several disclosures, so I list my own disclosures here on this first slide. In addition to this, our other speakers also have disclosures which are relevant here. And finally, this is Jean-Vive's disclosures, and then Hussein Tawbi also has some disclosures. And so the planning committee and content or peer reviewer disclosures are listed here as well. And there is a disclosure of unlabeled use. There will be a discussion of some unlabeled use, as well as a disclaimer here as well. And so with that, housekeeping notes aside, I will just say, please do visit us at peerview.com/melanoma22, where you can view the slides and practice aids now, and you can download them after this event. And so just to really kick it off, I wanted to show here a timeline of immunotherapy advances in resectable melanoma. We know that the first FDA-approved agents in the setting of patients with stage 4 melanoma were approved in 2011. However, in pre-2015, adjuvant therapy was interferon-based, and I think many of us can remember that and the trials and tribulations of that. But since then, we had the approval of adjuvant ipilimumab in 2015, nivolumab in 2017, and then pembrolizumab in 2019. And now adjuvant PD-1, or pembrolizumab, was just approved for stage 2B and C in December of 2021. So huge advances already. And we'll also discuss the potential for neoadjuvant therapy. And so why are we here, though? And I think what are the unmet medical needs in resectable melanoma? And we know from recently published literature in two accounts, one from 2018 and one from 2020, that despite having this information out there, most patients still receive a watch and wait approach, if you will, who have high-risk disease that's been resected. And so I think there's still a lot of learning opportunities here for us as surgeons and for us as a global cancer community. And so we will have seminar and tumor board sessions included in this. And so for today's agenda, we will kick it off with some evidence for adjuvant immunotherapy in patients with stage 3 and stage 2 melanoma. We'll talk about the latest on neoadjuvant immune-based treatment. And then finally, we'll also weave in some case-based discussions throughout the presentations. And so for our first presentation, it's entitled Expanding the Role of Adjuvant Immunotherapy in Resectable Melanoma. And our speaker on this topic is going to be Dr. Hussein Tawbi, who's the Professor of Melanoma Medical Oncology and the Deputy Chair and Director of Clinical Research and Early Drug Development at the University of Texas MD Anderson Cancer Center in the Department of Melanoma Medical Oncology. And I can tell you that Hussein and I work closely together. We often debate this very topic, very timely. And so it's my great honor to have him here tonight to be able to speak with you and to share his words of wisdom. So Hussein, would love to hear from you.
Thank you, Dr. Wargo, for the introduction. I'm really excited to be with all of you this evening discussing the evidence for adjuvant immunotherapy, and we'll also take a look at what the future might hold. So as you know, the current era of adjuvant immunotherapy includes the immune checkpoint inhibitors and BRAF and MEK inhibitors. Of course, we still have approvals for the interferons. However, those are much less likely to be used. And we're going to be going over the evidence that supports ipilimumab, nivolumab, dabrafenib and trametinib, and now pembrolizumab in the adjuvant setting. And I have to say, if you look at these hazard ratios, you see that each of them are significant, and they're each capable of decreasing the risk of recurrence in our patients with stage 3 melanoma. If you look at the NCCN guidelines, all of the anti-PD-1 and BRAF and MEK inhibitors are recommended and approved in the stage 3A to 3D patients with melanoma. The PD-1 is preferred, as well as the BRAF and MEK inhibitors. We'll be talking later today about how to potentially approach clinically node-positive patients, but all of those agents, the PD-1 and BRAF-MEK, are Category 1, and they're also for Category 1 for stage 3 in-transit disease. And we've made an expanded version of this resource available that also features dosing information on adjuvant therapy that you can download for treatment planning. So to look at the exact result of these studies, Checkmate 238, I think, is one of the pivotal trials that compared anti-PD-1 antibody nivolumab to the anti-CTLA-4 antibody ipilimumab. As you know, ipilimumab is given at 10 milligrams per kilogram IV every 3 weeks for 4 doses, and that had been the standard of care. It had been shown in a placebo-controlled study to decrease the risk of recurrence in patients with melanoma. And nivolumab here, as you see, has a hazard ratio of 0.6. By about 50% or 45 to 50% is extremely helpful. However, we still, with the long-term data, we still see that we lose about half of our patients. They still recur. So the idea of intensifying therapy is really important. And the idea of using ipilimumab in combination with nivolumab has been used and tried in a phase 3 trial, Checkmate 915, that you see summarized on the left of this slide. To note, ipilimumab was given as 1 milligram per kilogram every 6 weeks in the study, and the hazard ratio was 0.91. That was, and the p-value was not significant. So we don't have any evidence that this combination improves the rate of the relapse-free survival for that population. Having said that, importantly, the Immunet trial was a study that used high-dose ipi-nivo, the standard dose that we use for metastatic disease, compared to single-agent nivolumab, compared to observation or to placebo, in a population that is high risk, that's resected stage 4, so metastatic disease that's resected. And the results are actually strongly in favor of using high-dose ipilimumab and nivolumab, and the hazard ratio compared to placebo was 0.23, so decreases the risk of recurrence by 76%. And also was favored over nivolumab alone as well, with a hazard ratio of 0.56. So with that in mind, that's why the stage 3 disease and resected stage 4 has basically standard of care is the use of immunotherapy, either as single agent or combination, and also potentially BRAF-MEK inhibitors. Stage 2 disease is not less risk. If you look at patients that have stage 2B and 2C disease, their risk of relapse and the risk of death at 10 years from melanoma is really high. It's in the 20 to 25% range, actually similar to patients with stage 3B, and actually worse than patients with 3A that actually already have a standard of care adjuvant therapy. So the idea of studying this population and using anti-PD-1 antibody makes sense. And Checkmate 76K is a study that randomized 2-to-1 patients to receive nivolumab versus placebo, patients with stage 2B or 2C. And this study, we're still awaiting the results. However, the results of Keynote 716 have already been reported, and this is a placebo-controlled 1-to-1 randomization of pembrolizumab versus placebo, again for patients with stage 2B or 2C disease. And the results are clear in terms of relapse-free survival, with the hazard ratio showing a hazard ratio of 0.65. So the use of pembrolizumab in this population decreases the risk of recurrence by 35% in stage 2 patients. And I think that's really important. That happens without decreasing the risk or without decreasing the quality of life for those patients, as you see in this curve that compares the placebo to pembrolizumab. You know, we know that these agents are effective. We also know that they have a risk of toxicity. As you know, when you basically turn on the immune system, it starts attacking all of the normal structures, and essentially every structure can be at risk of developing an inflammation and itis of sorts. So here's a list of all of the possible side effects. The reality is the grade 3 to 5 side effects, they happen only in about 14% of patients. Again, in the adjuvant studies, there was no 5. It was only grade 3 to 4. And the most common are typically pneumonitis, colitis. Obviously, we see a lot of skin toxicity. So that does happen. However, if you look at the management, really, most of them are managed either by holding immunotherapy if they're grade 1. Even if they're grade 2, you can consider topical steroids or sometimes a short course of steroids. Only when you're in grade 3 or 4 disease, when you have to use high-dose corticosteroids, most of those side effects resolve within about a 4-week duration of steroid use. Some of them are more refractory. Some of them require admission to the hospital and IV steroids. And potentially, if they're not responsive to corticosteroids, you may have to use other inhibitors like mycophenolate for hepatitis or infliximab and vedolizumab for colitis. However, again, the risk of those events happening is relatively small. So with that in mind, I hope I reviewed with you all of the evidence that supports the use of immunotherapy in patients with stage 3 disease. This is a population that has a really high risk of recurrence despite optimal surgical management. And adjuvant therapy with both targeted or immunotherapy is effective and, again, decreases the risk by roughly 1/2. I also reviewed with you that stage 2 patients can benefit from adjuvant therapy and that the safety profile is generally favorable in this population. We clearly and absolutely need biomarkers and other approaches to risk modeling that really can help us select who we should treat and who we shouldn't treat so that we can optimize the risk-benefit ratio. And I hope that in the next discussion, as we discuss some of the cases with Dr. Wargo, we'll be able to kind of go into some of the nuances of how we choose adjuvant therapy, and then again, how do we manage some of the toxicities. With that, thank you very much for listening, and I look forward to the discussion.
All right. Okay, so now it's time to test your knowledge. So before we move on, just take a moment to answer a follow-up question on the evidence supporting adjuvant immunotherapy in stage 3 and 2 melanoma. All right. Excellent. So the next part of this discussion, I will introduce Dr. Geneviève Boland again, who's going to take us to our tumor board and do some case discussions on adjuvant immunotherapy in resectable melanoma. Geneviève.
Thank you. Is the mic working? Yep, appears to be. Great. Thank you for the invitation. Nice to see you, Jen. Nice to see you all in person. This is a lot of fun. We hope that this is interesting and engenders some discussion, or at least we'll start the discussion. And already your questions are kind of attuned to where we're going. So Michelle, a 45-year-old woman presenting to your clinic with a 2.1 millimeter non-ulcerated melanoma of the left forearm. Standard of care, wide excision, sentinel node biopsy, and 1 out of the 2 sentinel nodes has scattered melanoma cells. So T2A with nodal disease, very, very low burden. BRAF V600E positive. So the next steps, these are the things we all are wondering. Any treatment, no treatment, active surveillance versus adjuvant therapy, and if one were to consider adjuvant, targeted therapy versus immunotherapy.
Should we ask Hussein?
Hussein, and then we can, are you there?
Should we bring him up on the screen? Bring Dr. Tawbi up? There he is.
Yeah.
Hi.
Hi, can you hear me, guys? Can you hear me okay?
Yes.
Great. Well, apologies for not being there in person. I'm in DC at the Melanoma Research Alliance retreat, where everybody's asking where Dr. Wargo is. So, and again, just a really quick thought. I really appreciate that on this week of the International Women's Day that I'm with two superb ladies. So I really appreciate you guys, and thank you for being leaders in the field. Thinking about this particular patient, I think it's really important to highlight the fact that we have patients that are at stage 3 because they have some evidence of lymph node involvement, but that doesn't always translate into an extremely high risk of recurrence. And we turn to our AJCC 8 definitions, and we see that with 49,000 patients, each of them had undergone a sentinel lymph node biopsy that were kind of used to derive the melanoma-specific risk of recurrence or the melanoma-specific mortality for each of those patients. We know that 3A patients have only a 12% risk of death of melanoma over the next 10 years, so 88% survival. So when you think about that, you really have to think long and hard before you throw any sort of systemic therapy on those patients. And so as we look at this lady with intermediate thickness but non-ulcerated melanoma and just the faintest of evidence of involvement in the lymph node, technically that would be a patient that sits on the spectrum of low risk stage 3A. Two quick thoughts on the clinical trials. You should know that COMBI-AD included patients with stage 3A, but they were required to have more than 1 millimeter of involvement. Interestingly enough, and this is a debate you may have with your medical oncologist, the FDA actually did not care. They just approved it for all stage 3 patients. So technically, you need to discuss with your patient that just because a therapy is available doesn't mean that it should be the preferred option.
Yeah, and Hussein, awesome input. Thank you. There was a question from the audience that I was hoping you can answer or opine on, and it's how can adjunct tests like gene expression profiling be used to identify high-risk patients who might need higher management intensity?
Yeah, that's a great question, and that's what we're all kind of after at this point. What are some biomarkers and predictors of recurrence that could, kind of better classify our patients? We know that actually clinical pathologic factors like depth of the lesion and ulceration and lymph node involvement are the most predictive, but we are hoping that some more kind of advanced technologies will help us. The truth of the matter is none of them that is currently available in the market are actually ready for prime time or prospectively validated to really be useful. Specifically, I would say some of them are actually designed to give you the risk of whether a primary should undergo a sentinel lymph node biopsy or not, and really not whether you should be, kind of going ahead with treatment or not. So we're at this point, there's some prognostic value, and people are trying to validate it, but it's not validated yet. And the hope is that as we evolve these biomarkers, we also have predictive biomarkers that can tell us how well our patients going to do with specific treatment. But the simple answer from a very long-winded answer there is I don't use any of these right now because none of them rises to the level of evidence to make me decide for my patients what would be best to do.
And just to echo that, from the NCCN standpoint, there is a biomarker panel that's looked into the evidence in very great detail, and currently there are no recommended tests either for the utilization of surgery or for additional adjuvant therapy. So agreeing with you.
Yeah, but room to iterate, for the scientists
sure.
and translational surgeon scientists in the room and listening in, there is a void and a need for appropriate biomarkers.
You're speaking my language. All right, I think we're going to get back to the next slide. So I think we agree. We wanted to point out that just because you have nodal disease, that's not all created equally. Again, Hussein already mentioned, or Dr. Tawbi already mentioned the burden of disease that was in the trial. So I think we can move on for the sake of time. So we switched it up a little bit, same patient now with more tumor in the node, so crossing that 1 millimeter threshold. Again, what would you do next? They are also BRAF V600E. Do you want to field this, Jen, or do we want to bring Dr. Tawbi back?
Well, I think this is a higher burden of disease in
Correct.
the node, right? And this patient does have a BRAF mutation, but I think there's a multitude of options here. I think certainly observation, close follow-up, but also adjuvant BRAF and MEK inhibitors, as well as adjuvant immunotherapy.
Exactly. So kind of what we summarized here. And I will say, and this is, I wish Dr. Tawbi was here in person so we could all interact a little more easily, but at my institution, I'm in Boston at the Mass General, we tend to be a little more targeted therapy heavy than other institutions, I would guess. I don't know, Dr. Wargo, you can tell me.
Yeah, I can tell you we lean a little more towards IO.
And I think that's probably more standard. But anyway, the data isn't there yet from a comparative standpoint. All right, great. So we just want to switch it around a little bit. This is a patient, obviously, with a higher risk melanoma, T4B, 4.3 millimeter ulcerated melanoma with 2 millimeters of disease in the node. Also BRAF V600E. But of note, the larger context needs to be integrated as well. This is a patient with a low EF and, with a cardiac history. So again,
yeah, I think we might call on Dr. Tawbi.
I think so.
He's who I would find if I had this patient.
Well, thank you. I mean, I think, again, every one of those cases, I look at them and immediately think that's a 40-minute discussion with a patient, because it's going to be a discussion about what is the risk of your disease coming back, what is the value of treatment or the utility of the treatment, that includes both the risk and the benefit. Again, you heard from my talk the hazard ratio of how much you decrease the risk of recurrence, and then the evidence of toxicity. And then 3, the patient's protoplasm and preferences, right, which are all kind of factors in deciding adjuvant therapy. So in this case, I think Dr. Boland made it very clear this patient has high-risk disease, and those are patients that you want to save with adjuvant therapy, try to cure at this stage when the tumor is still at its lowest tumor burden. However, and again, the risk and the benefits still we need to discuss with the patient, the long-term toxicities from IO versus the kind of higher incidence of targeted therapy toxicity, although it's a much shorter duration of toxicity, so they resolve once you stop the pills. But you also, again, talking about the patient's protoplasm, so this is a lady that is otherwise having, asymptomatic CHF, but her ejection fraction is on the lower side. We know that one of the very well-known side effects of BRAF and BRAF-MEK inhibitors is a depression of cardiac function, and patients actually have to undergo, either in the metastatic setting or in the adjuvant setting, they have to be evaluated with an echo and an EKG every 3 months while on treatment. And so you look at a situation like this, and you would say this is a patient that would be at a high risk of that toxicity, and that's quite significant, as you can imagine. Most of the time it's reversible when it occurs, but you really don't want to treat a patient like that with a drug that has a very direct side effect profile with cardiac function effect. So with that patient, even if it was at MD Anderson, or I would hope even Ryan Sullivan at MD8 will say, yes, this is not a BRAF-MEK appropriate patient, and if we have to treat IO, is it very appropriate for this patient?
Yeah, just to weave in some questions from the audience, we had 2 great questions. One is, any role for BRAF-MEK followed by maintenance PD-1 in resected stage 3 disease?
That's a great clinical trial. Let's do it.
Yes, and then this is a great one, too. I think, Hussein, we're going to tag you on this one, too. What's the approach in RA patients, both seropositive and seronegative in BRAF wild type, and how is that different from IBD on immune modulators, and is there a difference in 2BC and 3BC? So if we could pull up Hussein again, we're putting him on the hot seat for that one.
Yeah, no, thank you. Whoever asked the questions might have Googled me, because I run a national trial looking at the safety of a single-agent checkpoint inhibitor at this point in patients with autoimmune disorders. It's designed right now for patients with metastatic disease, but we actually allow adjuvant treatment patients as well. And the answer is kind of from retrospective data, there is, you can treat those patients safely. You may expect some flare of their disease. And so again, when you look at the risk benefit, the risk for toxicity is a lot higher for those patients. So you really have to really want to treat them. So most of the time it's if they have metastatic disease. Really in the adjuvant setting, we always look, again, I just told you about those two superb ladies you have on stage, and you know, you guys cure more melanoma patients than I'll ever cure. And so surgery definitely is still curative, and there is a significant proportion of patients that will not need systemic therapy. So I always balance those things, and you know, for a patient where we've done the resection, we're going to be able to follow them very closely, and we will always have those drugs available if the tumor recurs. I might choose to observe those patients.
Great. This is awesome. Can we give the slides back, please? Right. I think we can move on. And we were talking that Dr. Tawbi already showed. This is just a longer-term follow-up. Again, I think we can keep moving. So how would you now describe your skills and confidence in recommending adjuvant PD-1 therapy in stage 3 melanoma based upon factors such as tumor burden in the node, BRAF status, and comorbidities?
Good music.
Here we go. So let's see. So blue is pre, and yellowy green is post. Great. So average, above average, but certainly a trend in the right direction. So good. Hopefully we're making some progress here. So just to kind of cover the spectrum of what has already been covered in terms of the data, going back to the point that Dr. Tawbi made very nicely, and this is the data from AGCC showing stage 2C overlaid with the stage 3 groupings, showing that it does, you know, patients with high-risk non-nodal disease melanomas have outcomes similar to patients with lower burden disease or low-risk melanomas. So if Michelle had a 4.3 ulcerated melanoma of the left forearm, but with a negative sentinel lymph node, BRAF positive, what are the next steps? Dr. Tawbi, can we...
This is probably at least a 40-minute conversation.
Yeah, so I mean, I think, you know, we go back to those same three factors that I always take into account, right? So we know that melanoma is just that aggressive, and it's a disease that is just designed to spread. And so even if you didn't get to the lymphatics, you know, you still have a pretty high risk if you have a thick ulcerated lesion. And so obviously we knew that we needed this kind of study as Keynote 716, and really good to see that treatment was superior to placebo and decreases the risk of recurrence by, you know, 35%, as we discussed. There are no data for targeted therapy, so to be clear, the only indication right now is for the use of immunotherapy. But then again, when you look at a hazard ratio of 0.65, that's great for, you know, a clinical trial to be reported and for a nice p-value. But what does that mean for a patient? You have to actually put it again in terms of absolute risk, absolute risk reduction. And so if you put this patient's risk at 25%, you do the math, you can decrease that by about a third. So you have to sit with them and say, look, I can take your risk from 25 to maybe 17, 18%. I don't know if I did my arithmetics correctly. But that's basically what you have to talk about with the patient and decide with them whether they're interested in being on this treatment for a year with the risk of 15% toxicity. Granted, the toxicity, just to be clear, about, you know, the vast majority of that toxicity, as I tell my patients, translates into a month of steroids, right? That's like the vast majority of that 15%, probably 12, 13% is just going to be a month of steroids and then they're fine. Obviously, there's 2 to 3% that is going to be long-lasting. We have some, you know, all of the bad stories of type 1 diabetes, of my patients that I have a patient who developed a myasthenia kind of syndrome and took a couple of years to get better, you know, and now they're fine. But this is not an easy decision, and I think having a tool in hand is a very, very good thing. How to use it is very important. And so I think back to what Geneviève was saying, we really need biomarkers in this population. And you know, a lot of us are doing research in that space. I can tell you, Jeff Kirschenwald and myself, at Emily Anderson and Jen Wargo and the Moonshot group is really interested in that population, trying to really understand how to look at the primary and determine what to do next. But yeah, definitely 40 minutes.
Exactly. Many of these decisions, I tell my patients, they're not algorithmic, right? They're a conversation. So let's see. We said multiple options. There is an FDA-approved adjuvant option that is, I was going to softball him the question about targeted therapy, but yes, currently it's PD-1 monotherapy. And this was just the subgroup analysis from the Keynote 716. And interestingly, and a little counterintuitively, the lower burden disease seemed to perform well, but having seen this presented elsewhere, I think the data is just early and not yet mature enough, and it probably is going to phase out, that probably both patients with those sort of lower risk, T3B and T4A and B, may gain some benefit. So based upon what you just learned, how would you now manage an adult patient with BRAF mutant stage 3C melanoma at high risk of recurrence after resection, if the patient is willing? Obviously, we've already stated that this is a conversation. Cue the music.
Yeah, Genevieve and I were commenting that this brought us back to our high school days, guys.
Pre-post observation, no additional treatment. So there are many fewer people are unsure, which is great. Many people are in the observation camp and then kind of distributed across. But yeah, I think this is an evolving field. I don't think there are right answers. So I think we're all just kind of figuring those out as we go. So on to the next session. Here we go.
All right, and so now it's my great honor to talk a little bit more about how we can link neoadjuvant immunotherapy to more effective surgery and improved melanoma care, a subject near and dear to my heart. And so what's the rationale for neoadjuvant immunotherapy or pre-surgical, and why might it be better than adjuvant treatment? And certainly response to therapy can be determined per each individual patient, which can help guide the need for additional adjuvant therapy. In addition to this, you can potentially reduce tumor burden before surgery. You can utilize pathologic response data as a surrogate outcome marker for relapse-free survival and OS. In addition to this, in the case of T-cell checkpoint blockade, neoadjuvant therapy can actually induce a stronger and broader tumor-specific T-cell response. And finally, easier baseline biomarker identification due to more homogeneous patient populations. And so there's a lot of clinical reasons. There's also a lot of preclinical reasons. And so there have been studies published in mouse models that show that if you actually treat mice with neoadjuvant immunotherapy, it is superior to treatment with adjuvant immunotherapy, though this has not yet been proven in patients. And why might it be better to treat with neoadjuvant versus adjuvant immunotherapy? Well, this is a figure from Caroline Robert, who actually had a beautiful write-up in Nature Medicine when there were 2 back-to-back papers that came out, and basically showed that if you have a tumor in situ and you give neoadjuvant immune checkpoint blockade, you can actually auto-immunize the patient by having that tumor in situ, and you get complete tumor kill in the rest of the body, whereas if you resect that tumor, it makes it more difficult for the immune system to actually really kind of identify the micrometastatic lesions, and it's less effective, at least in theory. Now, how about neoadjuvant targeted therapy versus neoadjuvant immunotherapy? Well, the phenomenal paper was published in Nature Medicine a little over a year ago by Alex Menzies and others, part of the International Neoadjuvant Melanoma Consortium. They did a pooled analysis, reported this data at ASCO, and basically showed that if patients are treated with neoadjuvant immunotherapy, for those patients who achieve a pathologic complete response, partial response, they actually have nearly 100% long-term survival, where it's only those patients who fail to achieve any response whatsoever who do quite poorly. Now, contrast that with treatment with neoadjuvant targeted therapy, and what we find is that patients who have a path CR do fairly well, but those patients can still relapse. But if they have anything less than a complete response, they're actually at very high risk of relapse. And so hence why we down in Texas tend to favor use of at least neoadjuvant immune checkpoint blockade over targeted therapy, although there are some interesting advances coming up soon. Now, how about neoadjuvant combined checkpoint blockade targeting CTLA-4 and PD-1? Certainly in the setting of a study where Christian Blank and others looked at adjuvant versus neoadjuvant Ipi-Nivo or CTLA-4 and PD-1 blockade, what they found when they looked in the peripheral T-cell repertoire is that they found in the context of patients who were treated with neoadjuvant versus adjuvant, they actually had more tumor, specific T cells in the periphery. But the problem was that toxicity was high with this dosing regimen that they used, and 90% actually had very high toxicity, making the standard dose unfeasible for broader testing. Fast forward a couple of years, in the same group, Christian Blank and others actually ran a study with Georgina Long and ran this Opus and Neo study, which actually identified neoadjuvant Ipi at 1 milligram per kg with Nivo at 3 mg per kg as the optimal treatment scheme. And so what they did is they took patients who were being treated with neoadjuvant and then randomized them to one of 3 arms. They either got 2 doses of Ipi-3, Nivo 1, 2 doses of Ipi-1, Nivo 3, the so-called flip dosing, or they got sequential Ipi and Nivo. And essentially what they found is the kind of the secret sauce, if you will, was the flip dose Ipi-Nivo with Ipi-1, Nivo 3. And they found it maintained efficacy but substantially reduced the toxicity. And so again, flip dosing appears to maximize efficacy, limit toxicity, and again, that's the Ipi-1, Nivo 3, and that's kind of what we generally turn to in patients. And interestingly, they actually had a paper in Nature Medicine as well, identifying biomarkers of response with TMB and interferon signatures. And really the follow-up so far has been pretty dramatic. Here's relapse-free survival after 2 years of follow-up with pathologic response, predicting outcome. And you see if patients have a pathologic complete response, they're very likely to derive long-term benefit, whereas if they fail to achieve a pathologic complete response, it's a pretty good surrogate that they're probably going to do poorly. And if you look at the IRAEs, or the immune-related adverse events, in the setting of treatment with Opus and Neo, what they found is that though there were immune-related adverse events, they tended to diminish over time. And the majority of toxicities occurred within the first 12 weeks. Only 4 patients developed their first high-grade IRAE beyond 12 weeks. And can we limit, there's a great question on here, is can we actually limit surgery in patients? And this is a phenomenal study, the so-called PRADO study, asking the question, can therapeutic lymph node dissections be omitted for certain patients after neoadjuvant Ipi-Nivo? And so this is a study where they took patients with stage 3B, 3C, de novo or recurrent melanoma, did RECIST measurements, gave them 2 cycles of the Ipi-1, Nivo 3, and then if they had a pathologic complete response or a near path CR, or what we call an MPR, a major pathologic response with like less than 10% viable tumor, those patients, they just had a resection of the index node, did not undergo completion lymph node dissection, and were just merely followed. Whereas if they had this resection of this index node and there was no pathologic response, or there was over 50% viable tumor, they went on to have a completion lymph node dissection and then went on to adjuvant therapy. Now, how about if they had a middle ground between 10 and 50% viable tumor? Then they underwent the completion lymph node dissection and had just follow-up CT rather than getting adjuvant therapy. And this, like this type of a scenario happens from time to time. I actually saw a patient a few weeks ago who, elderly patient, had neoadjuvant immune checkpoint blockade, had a great radiographic response. Actually, they called me from the holding area before surgery and said, she doesn't want an endotracheal tube. Can you do anything under local? And I'm like, the only thing we can do is like a modified Prado, right? And I'll send it off for frozen, see if it's a path CR, and we could stop there. But they opted for the whole therapeutic lymph node dissection for what it's worth. But we need to do more of this, right? Because are we doing too much surgery? Absolutely, we probably are. Now, what's the take-home from Prado? So after neoadjuvant Ipi-Nivo, the quality of response may drive subsequent treatment decisions. And so Prado actually confirmed the high pathologic response rate and safety observed in the previous Opus and Neo Arm B, okay, that Ipi-1, Nivo 3. Pathologic response rate, 71%, right? Grade 3 or 4 IRAEs, was 22% in the first 12 weeks, and therapeutic lymph node dissection was omitted in 59 patients, 60%, okay? So pretty impressive. Now, how about toxicity, though? And I think all of us, as we've rolled out immunotherapy and immune checkpoint blockade to patients with earlier stage disease, we've certainly seen, and in the surgical setting, we've seen a lot more toxicity, and I think we all need to be aware of this. This was a paper that Beth Helmink, who's now at WashU, put out on considerations for the surgeon with regard to toxicity for immune checkpoint blockade, and goes through the scientific rationale, but also shows the different timeline for different types of toxicity, and I think this is a really good read for anyone who wants to use this as a resource. Now, how about next generation combination strategies? How about LAG3? Well, LAG3 actually regulates a checkpoint pathway that limits activity of T cells, and LAG3 and PD-1 receptors are overexpressed or co-expressed on tumor-infiltrating lymphocytes in melanoma. And so there's a real rationale for using this. And LAG3 itself may limit IO response in naive patients, and it may contribute to resistance in IO therapy experienced patients. And so there are now ongoing studies looking at combinations of nivolumab and relatlimab. Sorry, it's a harder one to say. And Tawbi actually had a great publication just out in New England Journal. Nonetheless, there was a neoadjuvant PD-1 and LAG3 trial that was run by Rhoda Amari and others, and she presented this data at ASCO. And it does appear to be a promising strategy. Saw a pathologic complete response in 59% with a non-response in only 27%, and also some near pass CRs and also a PAP PR. So stay tuned for hopefully more of this data to be in print at some point in the next few months. So what are take-home messages on neoadjuvant therapy? Well, one, I think, is that use of neoadjuvant targeted therapy as well as single or dual checkpoint blockade appears to be relatively safe. The long-term benefit, though, is superior with dual immune checkpoint blockade. Toxicity is highly dependent on the dose and schedule, and this so-called flip dose CTLA-4 and PD-1 regimen does seem to maintain efficacy and reduce the rates of IRAEs. And then, of course, next-generation strategies will focus on limiting the extent of surgical intervention, Prado style, as well as identifying biomarkers and targets of therapeutic response and resistance. That's a key here. And also novel combinations like PD-1, LAG3. And so with that, we're moving on to our next test your knowledge. So before we move on, just take a moment to answer a follow-up question on evidence supporting neoadjuvant immunotherapy with PD-1 and CTLA-4 or LAG3 combinations. And music, please, Maestro. All right, so I think it's time for our tumor board again. Genevieve.
Yep. All right, moving on to the neoadjuvant setting. Let's see. So Robert presents to your clinic, 65-year-old gentleman presenting with a 2.5 millimeter ulcerated melanoma on the left leg, but with a palpable inguinal lymph node about 2 centimeters in size. We do a core biopsy as a standard to confirm that this is, in fact, metastatic melanoma. We stage the patient, in this case with PET-CT and a brain MRI, that shows no distant disease, but is positive for a single PET-avid inguinal lymph node, good functional status, and is BRAF V600E. So what are the next steps? Do you want to bring back Dr. Tawbi, or Jen, do you want to take this one?
Well, I'm going to turn it back to you, Genevieve. What would you do at Man's Greatest Hospital?
Well, it depends on what clinical trials we have available. So I think an important part of this conversation is, there are no FDA-approved neoadjuvant therapies. And so for many people, and actually this is one of the questions that popped up in the thread, is what do you do if you don't have a clinical trial open? I will say, and this may be a conversation rather than me just rambling, is that during COVID, the NCCN and other guideline organizations made it more flexible for us to use neoadjuvant off-label because it was necessary given the sort of constraints on the OR. And I think that has certainly in our institution increased the appetite for utilization. Before we would only use it on clinical trials, and there are now sort of cases in which we can sort of talk them into it. But I think that's an important component. What about you?
Yeah, I think certainly we aim to have clinical trials open for these patients, and that's of course the optimal really strategy to enroll them onto clinical trials so that we can learn as much as possible. That being said, I think for depending on the patient, sometimes we will offer off-label, and especially, again, like during COVID when we've had to cancel OR, et cetera, it made it a little bit easier to justify that, but even post, well, I hope post-COVID.
Post the worst, maybe.
Yeah, post the new era, I think we still are using it, but I think there was a question here on, let me see. I think we answered that. Oh, how to participate in multi-center neoadjuvant trials and or new trial development or otherwise incorporate neoadjuvant therapy if no trials are currently available at a center. I think that's really good, and we might tag Tawbi. He gets all the hard questions today.
Well, so I specialize in long answers. So let me start with the question about whether we actually treat this patient or not. I just want to remind everyone that, remember that patients with a palpable, clinically detected lesion is already going to be 3B, more likely 3C or 3D disease. So if you look at the risk of recurrence and death, you're already talking about patients that are at the risk of death from melanoma at about 40% if you're 3C. If you're 3D, 75% of patients will die in 10 years of melanoma. So this is basically metastatic disease in disguise, right? And so you absolutely want to give those patients the best survival. If you do resection and an adjuvant, remember you can only decrease the risk by a half, but you've seen the data that Dr. Wargo just showed with these flat curves after you get a response, right? So you decrease the risk of recurrence dramatically with a response. And we know that single agent in the neoadjuvant setting is just not enough. So if you really want to intensify therapy, that's how I think about it. This is why we use neoadjuvant for patients with palpable disease. So I absolutely, the data is not to the point of being an FDA-approved therapy or recommended therapy yet, but so far it's pretty convincing. So that's why we go that way. The way to get involved in clinical trials is not simple. The first question you should ask yourself is if you actually have the the staff and the abilities to run clinical trials. And if you do, please reach out to the International Neoadjuvant Melanoma Consortium. We've tried to, and Dr. Wargo has been a leader in this as well as Dr. Boland, to really put together all of the researchers globally that are interested in this. And we have over 250 investigators. We try to bring everyone together. Before the pandemic, we were there every single major conference. We had a small gathering for the International Adjunct Melanoma Consortium. It's been a little more difficult, but we're still absolutely going strong. And most of those data that you saw was actually pooled analysis with collaborations among the group. So that's a resource where we're actually trying to list all of the trials that are available, but we also have kind of a gathering of all of the investigators involved. So maybe, Jen, you could address how we can get more people involved in that effort.
Yeah, no, I definitely think that's a great way to do it. I will say, COVID, again, it put a bit of a damper on that, and it's, I think, how do we resource this so that we can really provide the right resources for investigators? I think, and again, I think it's a moving target. I think we need to come together and really work together and work with organizations like MRA, FDA, and be able to drive these studies together. But real-world evidence, I think, is also, can we adapt and use novel ways of designing trials that are, a bit of less of a heavy lift for institutions that might not have, CPRIT and other things that are available to, to some other institutions. So I think that's a great point. But I think. Great way to do it. I think we need to iterate a bit and grow, especially in the setting of what we've learned over the last 2 years. But good question. Thank you, Hussein. And then I'm going to, someone had mentioned my use here of frozen sections. So our pathologist will not do frozen on melanoma for margins or for sentinel lymph node biopsy. Understood. Is there a protocol that your pathologists use so that they're more comfortable with the frozen section diagnosis? And so it's interesting. So I don't use this to guide extent of surgery at that operation per se, right? So what they did in Prado is they actually resected that index node closed, right? And then if they had, viable tumor, 50% or more, then they would go back and do the therapeutic lymph node dissection. What's interesting with these when you treat patients with either neoadjuvant checkpoint blockade especially, or sometimes even targeted therapies, you'll get fibrosis. And so if you see absolutely no viable tumor and a lot of fibrosis, it's reassuring and you're very likely to have had a path CR, but of course you haven't sampled the whole node. So I usually bivalve it, send a little piece off for frozen. If they see, marked fibrosis and no viable tumor, I feel better about it. But again, I still do the whole therapeutic lymph node dissection, so my pathologists don't necessarily love me for doing that, but it's kind of nice to get that information, but you still have to wait for the final pathology. So I don't think we have the magic answer just yet. I will say that our pathologists through the International Neoadjuvant Melanoma Consortium actually put together a white paper on how to process these samples and how to read out a path CR, so that is a good read. I think that was that in Annals of Oncology, right? Yeah, by Michael Tetzloff and others. So yeah, and Richard Scolier. So that's a good reference for any of the surgeons out there to bring to the attention of their pathologists and to know on your own too. So okay, great. I think we move on to the next one.
Yeah. Can we pull up the slides, please?
Thank you, Sing.
So we talked about clinical trial being optimal and kind of mentioned some of these. So changing the scenario only mildly, BRAF wild type. I think, again, I don't think we need to get into the weeds here, but any commentary on, in the BRAF positive patient, we talked a lot about IO, which I think is the preferred regimen. Here, it's not even really an option. So yeah. I think that's more straightforward. We already talked about flip-dose ipi-nivo and how that strategy has proved to be superior and the really importance of the pathologic response in the node. So, follow-up question now. What strategy would you now select when attempting to mitigate IRAEs after selecting neoadjuvant ipi-nivo for a patient with metastatic melanoma? Music. Here we go.
Flip dose, nice.
Yep. So yeah, number 4, we're getting everyone moving to flip dose. Perfect. Let's keep moving. So I think we're making some progress here. Robert, 2.5 millimeter ulcerated. Oh, we just did that one, did we not? Sorry, let me go back. So same gentleman receives neoadjuvant flip-dose ipi-nivo. However, in the midst of that has grade 2 hypophysitis. So one of the endocrinopathies associated with ipi-nivo as a potential therapy. We've talked a little bit about the management of IRAEs. We would manage them, but those patients would still go on to surgery. And generally, they tolerate it just fine. So here we go. Same gentleman, core biopsy, BRAF wild type. He got the neoadjuvant. Do we base anything on the depth of the response in the surgical specimen? So this is the question of sort of the
this is a great
opposite neo.
Yeah.
I guess one thing that Jen has pointed out, though, is that really opposite neo is a clinical trial to address this question specifically, and very few of us resect the index node only.
Right, for Prado. Yeah, the Prado
a la Prado style. So I think while we're all very interested in minimizing surgery, most of the time in the real world, you're going to do completion lymphadenectomy.
But I think it's an opportunity for us as surgeons in the States. The Prado study was done in the Netherlands and in Australia.
Yep.
So I think there is an opportunity in the States to really replicate this and learn from this.
Absolutely, and sort of Jen alluded to this before, and I'll sort of reaffirm. It's changing the way we think about patients with nodal disease. Whether it's and I tell patients if we're going to deviate from NCCN-based guidelines, they know that we are deviating from NCCN-based guidelines. But it makes me a little more comfortable when we do that in certain settings, either patient preference or whatever. And I've had a few of those. So we mentioned that we would, therapeutic lymph node dissection. However, we talked a little bit about Prado, but functionally, unless it was set up as a clinical trial, that's not the way we do the surgeries in terms of the sequencing. So this is one I think we all think a lot about. This is a gentleman with a 2.5 millimeter ulcerated melanoma, but with a very large, palpable node, 10 centimeter, bulky inguinal disease with several other nodes, all demonstrating, 3 or 4 nodes with PET avidity, no pelvic adenopathy. So resectable, but bulky disease. Good functional status, BRAF V600E, I think this is a patient that we would feel much more strongly about treating in the neoadjuvant setting. And so I guess I'll throw this to you, Dr. Wargo. Targeted therapy because it's bulky, or immunotherapy?
Yeah, and I'll tell you, I'm a fan of targeted therapy too. I love immunotherapy, and I grew up on targeted therapy, so I love targeted therapy too. And if you asked me this a couple of months ago, I would have said, oh gosh, cytoreduced with some targeted therapy, but then, come on the back end with immunotherapy. But maybe we should talk to Tawbi.
Yep.
Yeah, that's, again, thank you for reserving the tough questions for me. I appreciate it. So, I mean, this is a situation where you have to think about the long-term outcome, right? And actually, I think about having a BRAF mutation as just giving me one more option. So if I went with targeted therapy neoadjuvant, I can always switch to immunotherapy in the adjuvant setting. Again, this is not based on a clinical trial, and that's the next trial we probably should be doing. Which is in those patients, if you don't get the right response that you're looking for, you can switch to the other form of therapy. But as you just saw from the kind of the pooled analysis, the most predictable long-term outcome you get is with immunotherapy. And the size of the tumor didn't really necessarily matter. The only concern is obviously when you treat with immunotherapy, the response is not as predictable. Patients may not have shrinkage of tumors. So if you as a surgeon are looking at this and saying, because of that size, I may not be able to operate, as Bernd Sondag called it, the nearly unresectable patient, then you may be getting a much more clear and quick response from targeted therapy, so that may help your surgical approach. And that would be the reason to do it. Immunotherapy, as you know, either works or it doesn't, but it's about, some patients in which it doesn't, the tumor can actually expand in size. Even some patients in which it does, the tumor may expand in size with the kind of pseudo-progression pattern that, Jen has experienced multiple times with some of our common patients. So I think that's a question that's really, as a medical oncologist, I will absolutely need a tumor board and a surgeon that's honest about what they can or cannot do and what their goals for the patient are.
And Hussein, could you comment on DreamSeq and some of the other data that's been presented regarding use of targeted then immuno versus immuno then targeted?
Yeah, so that's in the metastatic setting, and as you know, all of the current approvals for targeted therapy or immunotherapy in the metastatic setting are all in the first line. So all of them are phase 3 trials in previously untreated patients. So speaking of 40-minute discussions, every time I have a BRAF mutated patients with metastatic disease, I had to sit down and again say, well, you could do targeted therapy, the survival is good, the PFS is good, but then the durable responses are the ones described with immunotherapy. So as medical oncologists, we generally were veering towards immunotherapy, but that was based on, gut feeling and kind of interpretation of the data. Until Mike Atkins took, almost, close to 10 years to run this trial, but the whole point was to actually randomize patients up front. BRAF mutated, untreated melanoma, go to ipi-nivo versus dabrafenib trametinib, and then switch at progression. And finally, we got the data back, and I was just talking to Mike today, actually, at lunch, and I told him the best thing about that study is the answer was very clear. There was a 20% difference in survival at 2 years, in overall survival, a 20% difference in favor of immunotherapy first with ipilimumab and nivolumab. So it's a pretty clear-cut answer right now, and so in the metastatic setting, we can now refer to that when we talk to our patients, and maybe shave off another 15 minutes of discussion. But how to apply that to the neoadjuvant setting is a little harder, just because obviously it's a different population, it's a different setting, but kind of highlights the fact that immunotherapy is just really powerful.
Great, thank you.
Thank you. And I think we have a slide. Can we get the slides back from DreamSeq? Did you? So we said that both options are DreamSeq, and you can see here the data that was just referenced. So ipi-nivo followed by dab-tram versus D&T first. And so I think that has been very, very helpful. Again, the question remains as to how it applies in the neoadjuvant setting. And I will just say, I promise that I'm not an anecdotal kind of care person, but I think that at least here, my appetite for immunotherapy and getting good tumor shrinkage has increased as we've optimized the dosing regimens. And so we do, in some of these, I had a patient very similar to this recently who had a tremendous response to neoadjuvant immunotherapy in terms of tumor shrinkage, very locally advanced tumor. So Anyway, my appetite for that is much higher now. So follow-up, how would you now describe your skills and confidence in determining the need for using neoadjuvant dual checkpoint blockade, including as part of a trial in patients with potentially resectable melanoma? That's maybe our last musical segment. I think so, yeah. There's a time, I think we're good. Above average. Great, guys. This is awesome. So hopefully this has been a good use of your time plus dinner. So let's see. Oh, sorry, I'm going to go back. And Jen, do you want to just comment as the neoadjuvant expert, just
where
so we're going?
Where are we going from here? So I think intralesional, I think, and especially for cold tumors or colder tumors like mucosal and things like that, along with other intralesional therapies, BRAF, MEK, triplets, certainly other checkpoint inhibitors beyond pembrolizumab monotherapy, Nivo, Ipi-Nivo, flipped and non-flipped dosing, and then LAG-3, and there's more coming down the pike. So I think a lot of optimism and a lot of opportunity in the future.
Awesome. I think there's a couple minutes. Oh, let me go back.
Yeah, we probably have 1 or 2 minutes for questions. I will have to peel off myself shortly. But,
yep. And I think we got through a lot of these.
Yeah, I think we checked off a lot of boxes here. One was, what are most effective immunohistomarker in melanoma for rapid progression of you? Yeah.
I wish.
No. It's certainly not necessarily the imaging, because I think you can have these nodal immune flares, especially in the setting of treatment with IO. So, we still need better markers for that.
Yeah.
CD8 PET, I think, is
yeah,
emerging.
we've been doing granzyme labeled PET as well.
Okay.
But I think there's still, so there's, I think, the non-invasive imaging and, biomarkers. I think these people have pointed out where the growth areas are, but we're just not there yet.
Yeah, exactly.
So TBD.
Exactly. So if anyone has any questions over the next minute or two, we'll take it. But if not, it's been a great evening. It's been a pleasure spending time with you live here in the room and also in virtual space. And it really is great to be back in person. So thank you.
Thank you all. I don't know how to get this thing off. This is incredibly complicated.